This chapter is an orientation to the advantages and limitations of cranial endoscopy, and further sections will help to delve into some of the specifics for some of the topics discussed here. We have no relevant disclosures. This is an outline of the chapter. We'll first talk about some of the history of endoscopic cranial surgery and then also talk about the instrumentations and general principles. We'll also talk about some of the indications for endoscopic intracranial surgery, as well as some of the limitations. The history of endoscopy is quite extensive, first beginning in the early 1900s with some of the major players of neurosurgery. However, during that time, limited development and use of the endoscope could be seen due to the limitations of the technology. And it wasn't until the 1950s, 60s, and 70s, with improvement of the technology, that you could start to see and use the tools a little bit more effectively. And in the 1990s, functional endoscopic sinus surgery really became the predominant way that endonasal approaches were used. And it wasn't until that time that you started to see combined ENT and neurosurgery teams that developed further refinements of the technique and application to various intracranial pathology, and this could be seen across all the other applications of endoscopy within different fields. Endoscopic instrumentations. Predominantly there are two types of endoscopes, broad lens endoscopes and fiber optics. Broad lens are the sort of rigid type that you're seeing on the side, as the fiber optics are flexible ones used commonly for third ventriculostomy and choroid plexus cauterization. The endoscopes can be rigid or flexible. Then they can have working channels or just be used for visualization. Various viewing angles can be used, and the sizes vary anywhere from 3 to 6 millimeters in diameter. Various light sources have been developed for these tools, each with advantages. And there's also been improvement in the camera and monitor technology. One of the other modern advents have been the endoscopic holders. These include various pneumatic or electromagnetic systems used to alleviate the need for an assistant to hold the endoscope. It's not favored by most surgeons due to the limitations of the technology, but it is something that can be used with intracranial endoscopic work. Endoscopy has been widely helpful in the treatment of hydrocephalus. It was the first use for the treatment of hydrocephalus, and currently further refinement of technique has allowed it to be used for endoscopic third ventriculostomy with good response rates, anywhere from 65 to 75% overall. And with the development of the ETV score, prediction of these outcomes can be better, such that surgeons can now help identify patients who would better benefit from ETV versus progress to just the placement of a shunt right from the beginning. And the ETV score helps to predict the 6 months success, and it's a summation of the age, etiology, and history of previous shunts in a particular patient. ETVs are also helpful in adults from various pathologies or tumors that can develop in adults. This is an example of what third ventriculoscopy can look like. Off to the left side, you can see a visualization of the foramen magnum, as well as the choroid plexus and thalamus striate vein. The septal vein is also shown as it meets at the junction. At the floor of the third ventricle, you can see just anterior to the mammary body is a typical site that a balloon catheter or stylet can be used to create a third ventriculoscopy. And out beyond the third ventricular floor is the membrane of Lilliput, which is often fenestrated to allow clean flow of CSF. You can see on the right side various endoscopic tools allowing the use of instrumentations through the guide catheters, as well as continuous irrigation, which is commonly used for this type of procedure. Endoscopy and the use of resection of intracranial lesions is also something that has more recently been developed. First described for the resection of colloid cysts in the 1980s. These have been treated with a better success over time. Up to 60-90% have been successfully treated without recurrence or complication. There is a higher rate in the literature of incomplete resection. This is also a sort of one-handed technique that you're not able to get that bimanual traction. However, it is a reasonable approach to consider for some cases. There have also been description of intraventricular tumors resected endoscopically, including sagas, exophytic low-grade gliomas, neurocytomas, cord plexus tumors, and intraventricular craniopharyngiomas. These are all kind of limited series and case studies. However, they have been reported in literature. And also in combination with the ETV, the endoscope can be used for sampling of various pathologies, often to allow patients to progress to neoadjuvant therapy. And here are some approaches to intraventricular lesions, often lining up with the particular lesion. In the upper left corner, you can see a approach in B where a third ventriculostomy can be performed for a mass-occupied lesion causing obstructive hydrocephalus. And then in the approach with letter A, you can see the various different angles used to get a biopsy of the tumor. And variations of this have been described depending on the locations of the tumor and the type of endoscope being used. Endoscopy has also been used to treat arachnoid cysts. Often these require the presence of a cyst that is in the ideal location, allowing safe fenestration into the intraventricular or cisternal space. And it is a technique that has been described with cysts in various locations, either in the middle cranial fossa or other locations. And here's an example of what this can look like. A cyst that is within the ventricle itself. Often you have to consider the use of adjuvant surgical tools such as navigational ultrasound, as you can sometimes get into these cysts and lose orientation because they can be smooth walled structures. Endoscopy has also more recently been used to treat intracerebral hematomas. These are sort of the competing surgical technique compared to catheter-based evacuation. And the endoscope allows for improved visualization and has been shown to improve hematoma aspiration. However, the clinical benefit and improvement in patient morbidity and mortality still remains controversial due to patient heterogeneity and surgical technique. Here are some examples of how that is used. You can see various tools, the Apollo and the brain path, which with the use of the endoscope have been used to evacuate these hematomas various locations in the basal ganglia or the thalamus. Skull base endoscopy has really been the most interesting development of the endoscopic tool. And this really progressed from the 1970s onwards and has allowed a real minimally invasive approach towards the access of the anterior, middle, and lower skull base using combined team approaches with ENT and neurosurgery. And it has really revolutionized the treatment of various pathologies that required much larger open cranial approaches previously. Endoscopy does help improve visualization of these various areas, and it does reduce some of the bimanual surgical manipulation and loses some of the depth perception you can get with the microscope. But for the right pathology, it can be a very useful tool. And endoscopy can often be used in conjunction with other open approaches as well, either as a hybrid approach or other approaches from the lateral face, head, and neck. And here are various examples of how the endoscope can be used to resect pathologies, including lesion on the left side, also sort of depicted on the right. You can see that same lesion and good visualization of the cavernous sinus shown in C with a downward movement of the arachnoid diaphragm showing good resection of this particular tumor. Endoscopy has been used for the treatment of cranial synostosis, helping to improve minimally invasive treatment of children that present with synostosis, usually single suture synostosis. Initially, endoscopy was used for treatment of sagittal synostosis, and then has been expanded to lambdoid, coronal, and metopic cranial synostosis. It allows for lower blood loss and treatment of younger patients earlier on, and can be combined with postoperative helmet therapy. It's often performed in conjunction with cranial facial plastic surgery teams. And here's an example of how that may look with the endoscope coming in anteriorly to resect the strip of bone. Endoscopy has also been used to assist microsurgical techniques. These can include anterior lateral skull base approaches, and even posterior fossa and retrosigmoid approaches are now being explored with the use of the endoscope. And it does really help with improving visualization of various areas that previously had more challenging visualization. And overall, here's some advantages and disadvantages of the endoscope. It allows a wide angle view, better visualization at the site of surgery, and the ability to look around corners, and reduce retraction of neurovascular structures. However, you do lose binocular vision and depth perception. There's a learning curve to working with the instrumentation that occupies some of the surgical corridor. You need an assistant or an endoscopic holder to perform bimanual surgery. So it requires a team-based approach. It's just something that has to be developed. And instrumentation is very specialized to be able to do this sort of work, and is still an area of active development.